Hi, good afternoon. It's a pleasure and an honor to introduce Sheila Chauvin to you. I would like to think of her as a friend now. We met a few years ago as colleagues at MedEd Portal, and I think she is one of the most impressive educators I have ever met, on the ilk of David Irby and Joanne Wilkerson. So her resume is so incredible that I cannot remember it, so I'm going to have to read you most of it. So she got her BA in Special Education and Elementary Education, and then her Master's in Education and Curriculum and Instruction from the Nichols State University in Louisiana. Then she got her PhD in Education Administration and Supervision at LSU Baton Rouge. She has also done postgraduate work and certificate work in education leadership and supervision at Southeastern Louisiana University. From 1995 to 2002, she was at Tulane. She was the founding director of their Office of Education Research and Services. She created the Society of Teaching Scholars and was recognized for her contributions with 2 student awards, Special Advocate for Medical Education and the Clifford Newman Award for Medical Student Advocacy. Since 2002, she's been at LSU. She is the founding director of their Office of Medical Education Research and Development. She's also the founding director of their Academy for the Advancement of Education Scholarship, which is like our institute. She's a tenured professor at LSU in the Health Sciences Center, and she's an adjunct professor at Tulane in the School of Public Health and Tropical Medicine. She has many accomplishments. She's invited as a consultant and a presenter all over the world, nationally and internationally. She's recognized for expertise in education research, faculty development, teaching and learning effectiveness, curriculum and assessment development, education leadership and change process, advising and mentoring learners and faculty. She helped develop the peer review process and the criteria for education scholarship for both MedEd Portal and HEAL, and also was on the editorial board and is an associate editor now for MedEd Portal. She's faculty of the MERC program, and she's going to give 2 workshops tomorrow that's run through the AAMC. She also was the founding co-director of the Leadership in Education and Development Certificate Program that's sponsored by the Southern GEA. Is it Southeastern?
It's the Southern and now to the Central, and I've just been talking with folks to move it up here to the Northeast. So maybe available, maybe not this year, but next year.
And she's had significant extramural grant support for medical education research projects. She had a 2-year ARC grant to evaluate simulation training and teamwork in the operating room. And she's going to talk to you today about the project where she was the PI and project director, looking at, it was an academic community health center initiative to develop a model to facilitate teaching in community health centers.
Okay without the microphone?
We're taping it.
Oh, you're taping it. That's right. I forgot about that. No problem. Then I will tone it down a little bit. My husband tells me I have a big mouth, so I have to be careful with my volume. Do I have a pocket? Yes, I have a pocket. It's a real pleasure to be here. One of the unusual things that I was just sharing with one of you as we were waiting to get started was I found it to be quite unusual that it's actually colder in New Orleans right now than it is here. So I get a call home, and it's 30 degrees, and we've got 30-mile-an-hour winds, and I'm here with that. Yeah, isn't that unusual? So I come up here to get to warmer climate. I hope each of you have a CD. That CD contains everything that's in this binder. This is a project that I'll share with you a little bit of a background history on it before we get started. But rather than burn a lot of trees and have you carry stuff out, I thought you might prefer to have the CD. And if there are pieces to this model, the model as a whole, that you can find useful, either for creating rotations or experiences in community health settings, or it is adaptable to other kinds of collaborative education projects, you'll be able to use the tools because they'll be electronic. So there are Word documents and things like that that you could actually use and adapt. And so I wanted to be able to share that with you. So let me tell you how this project got started. I know one of you in particular will appreciate this. I was minding my own business in my office one morning, and I got a phone call about 11:30, and it was from my chancellor's office, Dr. Larry Ollier. And he had just met with the deans, and there was this RFA for creating a model for rotations in community health centers, and Dr. Ollier and the other deans decided that I was the best person on the campus to do this. My first response was, whoa, wait a minute, let me walk over. I'm sure that there's someone else, i.e. a clinician, who might be more appropriate for leading this project. Well, I didn't win that battle. So I went quickly to work and wrote the RFA, and we were funded. So let me give you a little bit of background on it. Well, first of all, it was a year-long project. It started out to be focused on the initiatives and the needs within Louisiana. I quickly learned, because I really had to go to school on some of this, I quickly learned that this was not something that was concerned just within Louisiana, but the concerns that we were experiencing there were quite widespread nationally. There were a number of people that were involved in this project. Ram Paragi was at the time in my office. He was a research associate I had brought on when I was doing the operating room teamwork training and evaluation. Tong Yang, a clinician but also a gifted statistician, was involved in this project. He's now doing his residency program in pathology. I'm really happy that he's doing that. And a number of other faculty and staff in my Office of Medical Education Research and Development. But there were other people who played instrumental roles in that as well. And that included the members of the Louisiana Primary Care Association, which was the organization that issued the RFA, and also the Health Sciences Center at large, Dr. Ollier's office in particular. The funding for this project was really quite small from the Primary Care Association. It was only $10,000, but almost $200,000 was devoted from the Health Sciences Center for doing this project, and so it really was an effort. We had over 35 faculty who were active in primary care specialties who participated in developing this model, and we had medical directors, site leaders, executive directors from all of the Louisiana federally qualified health centers. We also had representatives from all of the area health education centers across Louisiana. They have an LLC that they actually do projects with, as well as folks from the Department of Health and Hospitals, the system level office of LSU for Health Affairs, and a number of other stakeholders in community-based health and health issues in Louisiana. For today, I won't be able to share everything about this project with you, but I would like to accomplish these two objectives. One is for you to begin thinking about your own experiences in these sorts of endeavors and what have been your reflections on the individual and organizational features that either facilitate creating and sustaining an educational and academic rotation or an experience, for whether it's for medical students or for residents. What are those features that either facilitate that process or inhibit it, or actually outright barriers for you? So to be thinking about those experiences that you might have had in the past and what that's done for the efforts you've put forth. Also to look at some of the essential elements of this particular model that we developed, to see if there's some things that you can take away that you might be able to use either to enhance something you're doing already or to create something anew. So for today, I think what we'll do is spend just a moment to reflect on your previous experiences. To give you a quick overview of the model, I'll give you some information about the results from the initial development. I will go into more details of the model in terms of its practical applications, its feasibility, and its utility for what might be useful for you, and then wrap things up, and hopefully we'll have plenty of time for comments and questions. So let's begin with you. Just by volunteering some comments if you have to offer, what have been your prior experiences when trying to work with some community health site to create either an experience for a learner, like a one-week experience for a first-year student, or a full-blown rotation for a resident? Anybody? Yes?
I think it's really difficult if faculty, if the physicians there don't have faculty appointments here, because you're trying to buy their time and protecting their time when basically what's on their plate are all clinical responsibilities. It's very difficult.
Yes.
And so unless you have some sort of relationship where faculty there are supported at the academic institution, it's very difficult.
So let me just quickly paraphrase in case it wasn't carrying completely over to this side of the room. So the point being made that it's very, very difficult to establish a productive, sustainable rotation or experience if the clinical faculty at the community health center site doesn't have a faculty appointment. that there has to be that kind of a relationship development because you're buying their time. I mean, they're 100% plus in clinical activities, so trying to carve out a piece where they're going to slow down their productivity so that they can teach is an issue that has to be addressed. And that's certainly a very common one that's voiced, certainly across the sites in Louisiana, and it's prevalent in the literature on this area. Thank you very much. Any other experiences, positive or negative? Well, let me share with you a couple of things that I have heard oftentimes. One is that there's often competition between educational programs for sites. I would think that you have some of that concern here with as many health professions education institutions that you have in this geographic location. And then once you get one, it's hard to hang on to them. And so that's certainly, the revolving door can be a real challenge for you. Developing a strong relationship so that you have that sustainability is important, because a lot of effort goes into creating a rotation, whether it's going to be for the short term or the long term. So to be able to do that. Another one is that I hear faculty talk oftentimes about the widely varied experiences. That what learners get in one setting is not what they get in another setting, or what learners got in that one setting this month is wildly different than what they got somebody else got 2 months ago. So that continuity within the clinic and that comparability from one student to the next, or resident to the next, or from one site to the next is a challenge. The high turnover rate. The high turnover rate of the preceptors, the high turnover rate of the staff within the community health setting impacts the quality of what happens in terms of the learning, but it also impacts the productivity, the patient, literally the patient's senses of what can be accomplished when a learner is in the setting. There's a lot of high effort that goes into it, and oftentimes that effort doesn't result in a rotation or an experience. So you put a lot of time into conversations, you might be talking money, you might even get into doing an affiliation agreement, only to find out that the patients that your learners need to see in that rotation, they don't have enough of them. High confusion and frustration. So you thought I said this and I thought you said that. And we didn't really get down to the nitty-gritty details, and so what I was describing in terms of the kind of experience that a learner had, you shook your head, yes, we thought we agreed and understood, only to find out that the other person was thinking something completely different. And now the student's caught in the middle of it. Or the student goes in thinking that they know more than they know, and they want to start telling the staff how they could make their clinic run better, because they haven't been in that setting before. And so then the staff gets frustrated and annoyed by them, and they don't want to have students come in again. Some of the other things I heard from faculty as we worked on this is that the learner expectations are not clear. So it can be something as simple as showing up at a certain time, knowing what they can do or can't do, understanding the patient population that's being served in the setting. That the learner and the community health center interaction can be a hit or miss kind of thing. So what did we want to do? Well, we were hearing these things from faculty. We were hearing these things from the directors of the community health centers, and that's why the RFA came about. And in developing the model, I got to learn a lot from these individuals. And what we targeted, why would we even want to do this, which is my first question to Dr. Ollier, is why do you want to do this? Because he was very enthusiastic. He says, we have to have a proposal in for this. This is really important. So I asked him, and I asked the deans, why is this so important? And I went to the literature, and I thought it would be easy to find. And I found out there's not as much in the literature that I thought was there. But some of the answers to the why question included things like recruiting learners to primary care specialties we know is a challenge. Recruiting them to primary care practice in a rural setting or a health profession shortage area or a medically underserved area is actually even harder. No surprise to you, I'm sure. Recruiting them and retaining them. And it even goes to the other health profession staffs that are in the community health centers. That there's a lot of frustration, they didn't know what they were getting into. They find out it wasn't what they really wanted. So even the turnaround on nurses and dentists and dental assistants and social workers and the whole gamut. And that impacts productivity. The other thing was access to care. So what I found in this process was that one of the big incentives for the directors of the community health centers, again, no surprise to you, and somewhat a surprise to me, not as much as I guess I thought it would have been, is they want that relationship with the academic health center, mostly because they want to have that access to the tertiary care and to the specialists that the academic center offers. Well, in terms of a learner perspective, the answer to the why question was to enhance the learning experiences for all the reasons that I mentioned previously, to make sure that what they're having are active learning experiences that really reveal for them the practical aspects of the world of work in taking care of patients and being a doctor or being a nurse or being a dentist or whatever the health profession that's being targeted. That there are real-life experiences and that it really is a situated learning experience. And so the novice learners are on the periphery, but as they move forward, they get into more and more of the hands-on work. So to be able to scale that kind of learning in a setting so that students can continue to progress and try out what they're learning in their traditional classes. To learn other things like communication, teamwork, cultural competence, health literacy, leadership, advocacy, engagement in the community for community health issues and priorities. And also, which is certainly a buzzword these days, is interprofessional education. That it's important for our learners to learn how to learn, not just alongside each other, but with each other, to develop communications within the healthcare team. And the community health settings can offer those opportunities. But not that we're going to accomplish every single one of those things in a rotation, but to really design rotations to target the things that they may not be getting elsewhere in their curriculum. So the project really involved the Primary Care Association, the faculty at LSU, the 21 federally qualified health centers, and we did it in 2 phases. From February to June 2009, I did an initial comprehensive assessment of all of the FQHCs and their community health center sites. There were 50 of them. And then I engaged the faculty members and the community health leaders and other stakeholders I mentioned previously in designing the model. And the way we designed it was we looked at the literature. I did an extensive web search for other programs. And we really started with what has worked for you in the past, what hasn't, what's been your frustrations, what are your dreams. So really making it very practical. And then in the June to December segment, I did a follow-up to see what would happen once the model was out there and what kind of impact did it have. I won't have as much time to talk about that today, but I will try to touch on some of those things, and if you have questions, I will be happy to take those and answer those when you have them. Yes, sir?
So just to go back to the question of why.
Yes.
How much of this was from the school and learner perspective? Why do something like this? And how much of it was from the actual practice perspective? In other words, what are the practices in the community standing to gain? Did you ask that question as well?
Yeah, well, the RFA came out of the Louisiana Primary Care Association because the FQHC directors asked for it. So they didn't feel like they had a good connection to any academic site, not just LSU. We just happened to be the one to get the award. They were feeling like they would like to have learners, students, and particularly residents, dental hygiene assistants, and so forth, in their community health centers. But they didn't know how to go about doing it. It was so complicated, they couldn't figure out who to talk to, what to do, where to start. So it actually came from them. Good question. Thank you. These are the major components that I'd like to touch upon. Now, I'll give you a bit of background information on the initial assessment that was done with the FQHCs. We did a comprehensive survey that looked at what was there in terms of people, facilities, what kinds of rotations were already happening, just the patient census. I did the literature review and the web review, and I thought it was going to be easy. Honestly, I thought, somebody's done this already. Clearly, somebody's done this already. But I could find nowhere where there was a comprehensive model that could walk somebody through the steps in a very practical way. There were articles and reports of programs that were successful, but there was no evidence of how did you go about doing that. How could somebody actually start with step 1 and work their way through it? And so that's why we ended up developing a step-by-step model. The academic rotation model for the Louisiana project, and I've learned since that it applies nationally, was targeting residents and clinical students, that it was the community health center site versus other kinds of community based health locations. We wanted a standardized model that could help someone with a systematic approach, and that it could be appropriate for any kind of community health center or clinic, any specialty, and especially for the more complicated kinds of rotations that would involve learners from multiple specialties. So, family medicine resident with a family nurse practitioner, with maybe a social worker or pharmacy student. So those interprofessional where you're learning from and with each other, learning about, from, and with each other, versus just learning alongside each other. And that the model needed to be adaptable and flexible. Since then, I just will let you know that we've disseminated it. I've shared the model and the materials with folks throughout Louisiana and in these states and others. And some examples of real-life applications that have occurred right after we completed the model and disseminated it. We used it to create some family medicine student rotations that were very successful. And the model has become the foundation piece for a project across Louisiana that's been funded by HRSA, and this program is in other states as well, the Student Experiences and Rotations in Community Health, or SEARCH. And we've used that quite a lot in creating those kinds of experiences, and they're in their second year, and what they've established has been sustainable. And also we're working on it now, an interprofessional community health elective that will begin in January 2012. Just a tidbit of information here. So the survey, we had all 21 FQHCs involved, including all of their 50 sites. We did a web-based survey. We did 2 sets of reminders, and our response rate, 16 of the 21 FQHCs was 76% response rate, which I was very pleased with, and 33 of the 50 sites were represented, so 66% of that. In terms of what we learned, the physical environment, the questions gave us information about these community health centers in terms of obviously, I mean, their facilities are outfitted to take care of patients. Their teaching space is somewhat limited. So that's a barrier, that's a challenge that we have to work around, and some of it was really quite limited. They felt that their centers worked physically, they were effective for patient care, they're okay for the rotations with existing staff, but we also wanted to know about a capacity for expansion, and you can see from the slide that a fairly large percentage of these sites said that they had ways to expand. Now, I will tell you that it ranged from one FQHC was out in a very, very rural area. She had been very innovative and found funding, and she was taking an old school building and she was having it rebuilt as a dormitory. And all the way over to another community health center where they were just taking the end of a hallway and turning it into a little small area where they could actually have conversations with learners. So it was very widely varied. The resources, we wanted to know what they had to work with, and so you can see from the slide here that we were happy to see that 100% had internet accessibility. I was really pleased to see that 88% of the people in the community health centers had their own computers. Just 5 years ago, that wasn't the case. It was maybe 1 computer per clinic. So to try to do any kind of faculty development or sharing of information was going to be very difficult. At that point, we weren't involved much with the electronic medical record, but that's moving rapidly forward, and that's going to be an issue. What concerned me was the telemedicine, that there was only 25% that had access to that, and that was an area that was important to them and was also important to the faculty. So that was something we knew we were going to have to work on. We were also fairly pleased to see what the kinds of ancillary services that were available, as we knew that was going to be good for our different learners, especially if you're going to have interprofessional learning. Just a glimpse at the patient populations, just so you have some information, see how that might compare to what you work with on a daily basis. You can certainly read faster than I can speak. I'm not going to read to you. Again, these were quite a large range across the different services. In terms of patient care services, we had adult and pediatric, acute chronic wellness, and not surprising in Louisiana, hypertension and diabetes were way up there. I really don't need to worry about reading this entire slide, but what I do want to highlight for you is in these particular community health centers, in the adult population it was mostly chronic care. In the pediatric population it was mostly continuity wellness, preventive sort of things. We asked them about their staffing, and you can see that it was quite limited. But this represented the typical response from the different centers. So, they had a full-time family medicine. They had adult. Each of these FQHCs have to have dental services there, so that's why it's a little higher. And this is what sort of came out as the predominant areas and where we thought would be the good places to start with some of the models. And so family medicine, adult general dentistry. So that's why we targeted a family medicine rotation. We tried to couple a family medicine resident and family medicine nurse practitioner team to go out. And unfortunately, right when we were ready to implement that, there was a leadership change in the center, and we had to start all over again with establishing a new relationship. I think that's back on track. I hope it is. What were some of the things we learned from them in terms of benefits and motivators? And again, I'm sharing this with you because it's quite reflective of what you find in the literature. And I just did an update on a literature search, and there's about 20 new articles out in the last 2 years that are directly or relevant or somewhat related to this work. And these benefits and motivators or incentives, disincentives are still very much the case. They haven't changed very much at all, despite the efforts. So academic affiliation is really important to the community health center sites, not just because it raises their status in the community. To see a plaque on the wall that says you're affiliated with Mount Sinai or LSU or whoever, but also that they feel like they have a better route to the kind of specialized care when one of their patients needs that. They have somebody to contact, or if you have the telemedicine, you can get that connection. And so that's becoming even more important in my experience. It improves the retention and the recruitment and the retention. As I mentioned before, it's a revolving door. This was a really high incentive for all of the directors of the community health centers. In our search program, I just met with those folks about a week and a half ago, and I'm finding out that we're only in our second year, and there are already some of the folks that have been through search are getting hired as soon as they get graduated. They graduate from the program, they've got a job in one of these community health centers, and they know what's expected. They feel like it's a good fit for them, so the chances that they'll be able to retain them is good. The networking, staff satisfaction. People get their jollies out of preparing the next generation of health professionals. There's a giving back that's important to people. And that we can influence people's career choices in primary care if we just give them the opportunity to learn more about it. And this came from both the faculty and from the directors of the community health centers. Not surprisingly, I think to you will be some of the challenges. The concern that the productivity goes down. I mean, these community health centers are living off the revenues. They have very slim budgets, and so that they want to take a learner in, they feel like they might not be able to. So some of the faculty development that I might do with some of these folks is to help to keep the patient census up while they have the learner there. So some strategies for teaching while you're taking care of patients. Supervision. So sometimes there's a misunderstanding that they need to supervise everything or do lectures in the whole 9 yards, and that's not the case. That's where the model actually helps people identify what are the specific things you want that preceptor to do in the community health center, and don't worry about some of the other stuff. Space limitations was a concern, as I mentioned before. Where do they get their financial resources? Well, their financial sources, the individuals that responded to the survey, the percentage of respondents, you can see where they got some kind of support from the academic institution. That they did get federal support. That's a big deal for them. And that the community health center provides resources for a number of things on their own, i.e. comes from their own fundraising and from their revenues that they get from caring for patients. And in terms of clinical rotations, the high points that were existing when we started the project, you can see that predominantly medical students, medical residents, nurses, and there was some thought about doing some things in the future, but not a whole lot. Again, too complicated. It's going to cost me more than it's worth idea. So let's look at the model. Now the printed handout you have actually lays out the model and some of the steps, and I thought you just might like to have that in front of you. Since we know that adults don't like to take notes, but we forget 50% of what we hear within 24 hours, that it might be useful if you jot something down so we can up that percentage to 95%. All right, so this is the model. It's an 8-step model. It's designed to be a very flexible model. So if you're starting a rotation, and I'm using the term rotation, but it could be a 1-month experience for a first-year student, or it could be it could be an educational program where it's between internal medicine and pediatrics, or it's between neurology and neurosurgery, or between surgery and anatomy. In the 4th year as an elective. So it's about collaborating and developing partnerships and relationships and being clear about curriculum development. But we designed this model with a particular focus on the community health rotations, but I can tell you that you can adapt it for just about anything else that you might want to do. So you go through a new rotation, you're going to go through all of those 8 steps, and then when you get to the end, you may decide that you need to start all over again. Well, then you go through back the 8 steps. However, if you're developing a new rotation or one that needs to be substantially changed, you might go through each of those 8 steps. When you get back to step 8, your evaluation results indicate to you it was a pretty good deal. It worked well. We got good outcomes. The process worked well. All the efforts we put into the curriculum and the details and so forth worked. We just need to do a little bit of refinement. You may have to only go back to taking stock, doing a little bit more assessment of what's there to work with. Or you might not need to do that. You might need to just go back and do a little bit of refinement to get a better fit. Or you may need to just target some particular details that didn't work quite so well, and you just need to fix those and you're good to go. So it starts out as an 8-step model, but after going through that, if you can build a strong relationship and a good partnership, then maybe you only have a few additional steps to do as you keep things going. So the model, or in this binder, are the 6 sections that are in here. And really, the model, people look at this binder and they go, oh, gee, Sheila, I don't even have time to read this thing, much less do it. All right? But the model is only this much. And it's written like a mentor and a manual. So you open up, it's really good if you open up the binder, you print it out, put it in a binder, put your tab dividers in there for the 6 sections, and now you can go back and forth. Because in section 1, which is the model, everything else in there is referenced. And it's like having me or someone else sitting next to you and saying, okay, what do you want to do? Well, why do you want to do that? All right, let's identify what the purposes of this rotation will be. What's the goals? What's the objectives? What do you have to have in place? All right, well, pull out page 2.4. Let's use that one and identify the goals. All right, now on the bottom of page 2.4 says, what are the incentives or disincentives? Before you start picking a site, let's think about who would even want to do this, and can we have incentives outweigh disincentives? So it's like having somebody, a mentor sitting next to you and walking you through this if you've never done it before. All right, so every other page in that binder is referenced in the first section. Section 2 are the tools. So there's all kinds, and you don't use them all. You pick the ones that work for you. So there's worksheets. There's a guide for the first contact, the first discussion you have with the site director. Or if it's a site director that's looking for an academic program, it walks the site director through what do they need to have ready before they contact you to talk about it. How many meetings have we been in where it's been a total waste of time? We have a whole bunch of psychobabble. When the meeting's over, we shake hands, we smile, we go back to our respective places, and nothing happens. Or we agree to meet a month from now, and we meet, and then it's like, oh, I was supposed to do that? I didn't know that was I didn't know I was supposed to do that. I thought you were going to do that. So there's tools in there where you actually show up with stuff in hand, and then you go through that and you clarify what you each mean by that and come to agreement, and you lay out a set of tasks, an action agenda, and you sign off on it. There's something about having to sign off that makes people say, now what am I supposed to do, and making sure that they do it so that when you meet again, it's done and you don't have to retrace the steps. So section 2 gives you all those tools to do with it. And then it's not personal, it's performance and process. And it's not this way where you're facing each other, it's where you're sitting alongside each other and you're working through it together. Section 3 includes a whole bunch of resources, recommendations and strategies predominantly about developing collaborative relationships and facilitating change. Okay? One of the things that I've spent 37 years in is facilitating change, creating programs that didn't exist before and making sure that they sustain even when I'm not there. I'm really pleased to say in the 37 years, to my knowledge, everything I ever started is still going. I only hope it's better. and at least revise them to keep up with the times, but that it's sustainable. So in that section, if you've never been involved with the change literature, you don't need to go read all the books and all the chapters. You could if you want to, but here's some tools that you can use. Even if you're refining an existing program, there's going to be some change. Somebody's going to say, well, why do I have to do it that way? This seems to be just fine. Or you implement an innovation and the response is, how's that going to change my job or how people think about me here? So that section helps you with that. Section 4 are resources. So examples of resource sections in there, there's a section on cultural competency and a whole bunch of web-based curriculum that you can access for free. Not only to help the faculty, but help the learners. Health literacy. I co-chaired the legislatively mandated state committee on health literacy in Louisiana. What we found out in that process was that a lot of people didn't even know what health literacy was or how it differs from just educational literacy. And so there's a whole set of resources in there, in that section, the print resources and also web-based resources, curriculum resources. There's a whole section on faculty development. There's a section on how to write learning objectives. There's a section in there on how to develop curriculum. So if you haven't done that before and you feel like you don't have a resource you can go to, there's a place to start. And it's things you can take out and you can use to work with your partners. Section 5 and Section 6, the glossary of terms, and then also, because some of the folks, we don't understand some of the terms that are used in the community health center, and they don't understand some of the terms we use in the academic health center. So you have that there so people can have a conversation and understand the language that we're using. And then Section 6 includes things like an annotated bibliography and other citations and resources that you might find useful. So you don't have to go searching on it. You can have that there to actually get you started. Oftentimes, creating programs like this, and it's certainly demonstrated in the literature and in the more recent literature that I've found, complexity. Governance and administrative complexity is a major put-off. It's why people don't get started, and the hardest part is getting started, or it doesn't carry through into something that you actually have in place. That those are two of the major barriers, and so those kinds of things are in the model to help you with that. So let's take a closer look at each of the steps, and then we'll wrap this up for questions and comments. So in step 1, identify your potential partners. What I've learned from my colleagues and from the literature is oftentimes, oh, did you know Dr. So-and-so? Well, Dr. So-and-so is such a clinic. Really nice guy, a really nice gal. You think they could take some of our learners? Let's ask them. They pick up the phone or they shoot them an email, and they say, oh, yeah, we'll do that. But there's no more conversation about what do you want them to learn, who do you want them to see, when are they going to be there, how often. And so something falls apart, and the learner comes back before you know it saying, I'm not having a very good experience. And you go back to the preset, well, now they're defensive. And it's like a bad date. You know, we just kind of go in the opposite directions and we pretend it never happened. All right? And so what does that do to our relationship? So don't start by saying, who do you know? Start with, what do you want to do? So what's your purpose? Now, sometimes the purpose may be organizational or might be clinical. All right? So if a medical director or an executive director in an FQHC wants to have an academic rotation for a family medicine resident, they may not be very concerned about learning. You are, but they're not. They want manpower. They need somebody to see more patients. They don't understand the funding mechanism for residents. All right? So you have to think about what's their purpose. So when you have that first encounter, you can talk about what's going to float your boat. What's the incentive for doing that? All right? It may be clinical, it may be organizational. You know, maybe that to be in compliance with accreditation, we need to create some more community ambulatory-based experiences. And then, of course, the faculty are concerned with education and teaching. It was a very important educational experience for these medical directors and executive directors in this project to learn about learning versus manpower. They thought they were going to get a lot more money and a lot more manpower. It wasn't that they weren't interested in learning. They just had to shift their focus a little. And so that was important. What are the concepts? So in this work, there's a worksheet that takes you through, all right, so if that's what you want to do, so you write down your major goal, your purposes, your major objectives of what you want the learners to get out of this experience, not what you're going to do, not what the clinician in the community health center is going to do. What is the learner going to get out of this? All right, so what does that mean in terms of consequences? And we have to think about two sets of consequences, intended consequences and unintended consequences. Maybe an intended consequence is to promote primary care specialty as a career choice. Maybe it's to develop better clinical exam skills or better communication skills. Okay? So we have to look at what the consequences are, intended and unintended. We have to look at the incentives and disincentives. It may be that the administrative person in the community health center sees this as only more work for me with no more pay. So how can you have somebody from the academic side that's an administrator help to work with them so that neither person is burdened? It's those kinds of little nitty-gritty details that can sometimes undo a very good program. Erica, I don't have a watch on, so you could give me a time check?
Sure. It's 12:43.
Okay, great. Thank you. Step 2. Now you make your initial contact. Worst thing to do is shoot an email. And again, in the manual, in this section, in the model, it walks you through that to think about how you're going to make that contact. It needs to be the leader. This is not something you send a proxy for, or a secretary or an administrative person. This is where the head of the program needs to meet with the head of the center or vice versa. And it needs to be in person or at least by telephone if geographic distance is a problem. And if at all possible, make the first on-site meeting at the community health center site. And I go into detail, again, this is with input of 35 faculty and 50 community-based people. If you go to the community health center site, you get a lot more by seeing and talking and visiting with people and observing. You are trained observers. You will know very quickly if this is the kind of environment that's going to work for your learner or if it's something that can be adapted or adjusted. All right, so make the effort, get in the car, get on the train, the subway, go where you need to go to take a look at it. And it's on their turf, it's going to be a better conversation. And again, other details along those lines. There's lots of tips in that section in terms of building rapport, kinds of things to do with them, and then who to include. So sometimes the director might say, well, this first meeting needs to be with the entire, every community, all these FQHCs have to have a board, and their board has to be predominantly made up of their patient representatives. So they may want their whole advisory board to be there. Not the time to do that. You don't even know if you have something you can work with yet. But there is a time in a later step in the model where you do want to bring the board in because you want to have their support. And you want to have them generating some resources and revenues towards that experience so that it's sustainable. Other things in step 2 would be things like using the guide I mentioned earlier. And the WIFM is what's in it for us and me. And it's having that conversation of what's in it for us as a program, as a center, and what's in it for me. Taking stock. This is where we go and we do assessment of what's there. So if we're having dental rotation, so we have to make sure we have enough operatories. We have to make sure we have enough dental hygiene assistants that are there. We need to make sure we have board certified people that can supervise. If it's in medical students or medical residents, the same things apply. We need to have sufficient space so that they can see patients on their own. That's a place where you can consult and discuss the case privately. You have to make sure there's board certified clinicians to be able to supervise them on the days that they're going to be there. If we don't talk about those things, then we may end up doing a lot of effort and then it falls through because we didn't address those things. So taking stock of that, and there's a number of tools in the manual where you don't have to go create a new assessment checklist. We've got some that are in there, and you can adapt them. It'll trigger what you need to ask about. Sometimes things are so familiar, it's like the pendulum on a clock. You don't notice it. You're so familiar that you tune it out. You don't hear the air conditioning or the heating when it's on because you're so used to it. So these checklists will help you trigger things that you know have to be there, but you sort of take it for granted. So it becomes very useful when you do your taking stock. It also helps build the partnership between you and the community health center or vice versa. It may not be there, but what can they do to bring that forward and find out if they really are interested in working with you. Step 4 is achieve initial good fit. This is where you tabletop it. All right, so you decide this is workable. All right, so now you're going to start talking about the nitty-gritty details and laying out the plan, putting together what would be an initial implementation. You may decide to try to do a full-blown implementation is too much because the people in the community health center have never had learners there before. So you want to try small scale with just one learner for just 1 month. And let the things that look good on paper but don't happen in real life, let those come out while they're small and we can deal with that. So the small-scale pilots working out the kinks, getting the faculty and the staff, the clinicians, the administrative staff, accustomed to what each of their roles will be so it doesn't fall on everybody's shoulders is important, but also preparing the learner. I had multiple examples of where community sites didn't want to work with the educational programs again because the learners in their unbridled enthusiasm went in and were wanting to tell people how to reorganize their clinic and how to see patients and how to do different sorts of things because they thought they were helping them. And in fact, they were alienating them. They didn't understand that those community health centers didn't have the resources to work with that they were more accustomed to seeing in the academic setting or elsewhere. Step 5 is where you drill down the details, and some of these steps don't take a lot of time, but they're important to pay attention to. Drill down the details is where you actually play it out, get the manuals together. Now you talk about the memo of understanding or the affiliation agreement. If you did that back in step 1, that was the wrong timing. We didn't establish what the educational program was going to be yet, or whether it was even going to be something we could work with. But it's here now, and here's where you might need to bring in your legal consult for your affiliation agreements and so forth. Here's where you talk about the money. And then you play it through before you actually put the people to it, and that's what the bottom is. So imagine the movie. Play the movie together in your heads. Write out the script. Here's where you want them to show up at 8 o'clock on Monday morning, and where and who do they see? Because if they go search out you as the preceptor, they didn't need to come to you, and you missed seeing one of your patients because you had to deal with that administrative issue, whereas if they went to the administrative person, they would have been prepared for them, it would have gone smoothly, and you wouldn't have missed seeing that particular patient. There are tools in Section 3 that help with that in terms of strategies and resources. And then step 6 is put it into practice, and here's your initial implementation, and this may be your pilot, and it may be a pilot for 1 month with one learner, just to kind of get it through the, we sprinkle the human element and things don't work so well, so we have to give that chance to sort of flush its way out. And use the agreements and the planning documents, make sure they work, because then the next time you do it, it won't be so hard. It'll be much easier to do it. And here's a time where you need to have open and frequent communication, lots of checking in with each other. You don't want to wait till the end of a month rotation and then the medical director comes back to you or the executive director of the community health center comes back to you and says, that was an absolute nightmare. That student never showed up. They left early. Well, you didn't need to know about that, Dan. You needed to know about that on day 1. But they didn't want to be a bother to you. We didn't have a clear enough conversation of what's expected or even how to communicate with each other. So it may be that if I'm a director of a community health center and I'm working with you as the leader of the clerkship, director of the clerkship program, I need to know if it's easier to get in touch with you by texting you, emailing you, calling you, and you need to know how to do that with me so that we make the best use of our time and we establish a relationship that when I contact you, I'm not complaining about your program or your learner. I just have a challenge that I need to work it out. How do you want me to do that, or vice versa? We bring all kinds of beliefs in that sometimes we don't realize people have. And together we work out the kinks. We bring in the people we need. All right? It may be the administrative person, or it may be the nurse that can figure that out and solve that very easily, where we might make it a whole lot more complicated. And we celebrate the successes together, little successes, so we can move along and make progress. That's a change thing. And change process will definitely be alive. Let's hope it's well. In step 7 is, well, we've had that initial experience. Now let's sit down and let's look at what did we learn from that, what worked, what didn't work, what little adjustments do we need to make, what major revisions do we need to make. And this is a time where we actually want to make sure we have very close monitoring. It's important for the leader and those close to him or her to do that. It's important to have good documentation so we can go back and look at that when we're evaluating what that experience was like. And here's the point: we want to engage the frontline staff people again so we can have them help us problem solve where we can make things run more smoothly and be more beneficial. The last step is a critical step. It's evaluation. We talk about evaluation back in step 1, step 2. We start to address that, but we need to have a good, strong evaluation program in place, and then we use the results of that to make the adjustments in the model, both in terms of short and long-term outcomes, and we want to make sure that those outcomes influence which step we go back to. So if everything worked great, we were blessed, and the plan worked out as we anticipated, then maybe what we need to go back to is just revisit step 5 only so briefly, just to make sure we haven't overlooked anything, and then put it into practice large scale. But if we identify other things that need some work on that, then we decide where's the best place to start, and it's not always in step 1. It may be somewhere else. Okay? So, questions, comments? Yes, ma'am.
I'm curious, you mentioned only two of the behavioral health centers had electronic medical records. How did that work with the trainees? I think that's one of the barriers we've had. So we're contemplating have our primary care residents work at community health centers, longitudinal experiences. And the first thing that two different health centers said, well, our license is $500 per month per resident. It's already a lot of money. And then the second community health center doesn't have a program that allows a easy way to co-sign a note. They just don't, they're not in the academic model.
Yeah. Well, the electronic medical record issue is becoming an issue for us only now. Because at the time we were doing that project, the community health centers didn't use electronic medical records, and neither were we. It's very limited. So the effort that's moving forward now statewide, I know that I don't have all the details, but I do know that they're trying to do that across the board. So it doesn't matter, you know, we're Katrina country. So we're always thinking about what happens the next time our patients have to go somewhere else. And so making sure that everybody's engaged in this, so it doesn't matter. Wherever they evacuate to, their record will be available. Yes, sir.
To what extent do you find that you have to compete, I guess the wrong word to use, but compete with other schools and other groups of students who are all looking for clinical sites? I'm sure it's not the same as it is here, but probably there's similarities in that. There's so many medical schools.
Yeah.
There's such a huge influx of students from outside the state, from Caribbean schools. It's a big challenge for us.
Yeah. So the question is the issue of competition for sites for where our learners can go to. And certainly in your geographic area, you have a lot of people competing for preceptors and sites. And we have that to some extent too. Tulane is 2 blocks down from us. I used to be on faculty at Tulane. I'm on faculty at LSU. They learn alongside each other in our public hospital system in New Orleans. And so there is some competition that's there. But the model's for anybody. And many times in some of these community health centers, we have both Tulane and LSU and now Oxnard, because they now have a medical school in partnership with Queensland. So they can find places for that. It hasn't been too much of an issue. The family medicine rotations are sometimes a challenge, but I don't think that's even as much a challenge as it is anymore. What happens is if you end up with a less satisfying relationship, you have a very slim chance of getting back in there to try again. So that's where the model becomes really important.
Can I ask you just a follow-up?
Oh, sure.
Has anyone in the context of that competition started paying for rotation spots?
Not to my knowledge.
How do you assure the quality of the patient care and the role modeling by the physicians, especially in these FQHCs?
The question is, how do you manage the quality of patient care and role modeling by the preceptor or the supervising clinician? That's where faculty development comes in, and also being very clear about what's expected. So that's one of the main reasons this model was desired, so that working through these steps in a systematic way, you can, number one, be clear about the expectations, get to know the people who actually will be taking your learners, and by the time you work through that process, then everybody's comfortable and clear. And then follow up and giving support. So in the drilling down to the details and putting into practice, if you read through I will say when you read through the section, the model itself, there are issues where it helps you think about how to deal with someone who's not being an effective preceptor or is not giving the learner sufficient opportunity. And that's usually more the issue than not, that they're not giving the learner. A third-year resident ought to have a whole lot more autonomy than a third-year student. And sometimes there's that concern that they're not giving that because they're not sure. They're not sure what the learners have already learned. And so in part of developing the curriculum with them and the expectations, you let them know what the learners have already accomplished and how we measure their competency.
But that doesn't get at the quality of care. So if you have someone who's a doctor, they may be teaching your students and
Oh, well,
attention.
Yeah. These community health centers have lots of reports that they have to generate that are public documents. And so you can use those to look at indicators. And so you can use that as one measure of one way of looking at the quality of care that's given. And there's all kinds of metrics that are available. And you can ask these centers for the reports. You don't have to go search them out yourself. What we did in the follow-up phase of this project, we found that was one of the issues. And Erica, thank you for clarifying, because I wasn't following you exactly along those lines. We found out that the academic faculty weren't really knowledgeable about these different centers and who was there, what they were seeing, et cetera, and what were some of these published indicators. And so we created these little 2-page profiles for each of the community health centers, and we provided those to the faculty and the centers didn't even know about each other, and yet they met on a monthly basis, and so we gave them their profiles so they could share that with people. Their boards are very important. So look to see what the FQHCs are required to have advisory boards, and those boards have to be made up of a majority. I want to say 70% have to be patients of that community health center. It's a high percentage. And so when you're going through the model, you get to a point in the model where it's time to bring the board in. You want to have a conversation with the board to get their support, but you also want to know what they think about their center, what its strengths and weaknesses, what its unique features, what are areas that the professionals and the stakeholders don't feel like, they feel like that's an area they need to work on some more. Well, maybe that's not what you want your learners to experience. You're not going to do that part. They're going to do something else.
Well, thank you, and please stay for lunch. If you're not, please fill out your assessment form, take a CD.
Absolutely.
And sign it.
Yep. There's email addresses and there's phone numbers. We'd love your feedback. If you find it useful, let me know. If you have ideas to update it, let me know. And you can certainly share it with other people. I would just like to know that you've who you shared it with so I can follow it with them at some point. All right. Thanks very much.
Reminds me of the stages of change,
Yes.
behavior,
Yes.
pre-contemplation, contemplation,
Yes.
honestly.
Yeah.
Like,
No, that's in section 3. Yes.
Question
Yes,
for
ma'am.
you.
Uh-huh.
I'm the Deputy Director of the Public Health Program here at Mount Sinai. I want to know, with the allied health professionals, what role do the area health education centers play in this whole process?
In the search process, that's one of the professions that they're targeting specifically. So placing PT, OT,
through the area health education?
through the search program, and the students get stipends for that.
Okay.
Yeah.
All right. I'm going to check a little bit more into that. We have one here in the area, in the neighborhood in East Harlem now. And they just moved their headquarters to another location, so they said, please hold off for a while. But
And
we
especially,
wanna
if
work
you
with
can
them.
get them involved in a team,
Yes.
an interprofessional team.
Okay.
I've had some wonderful experiences with our allied health school, particularly with PT, respiratory therapists, and OT. We're in simulation, where we've actually created interprofessional teamwork simulation scenarios for training. And in the search program, the allied health is one of the targeted areas that they're placing students in these community health centers.
Terrific.
And they can do a 1-month rotation. They can do
Well,
a
our
1 month
students
now,
have
one
to do 150 hours practicum, which then often turns
That's
into
right.
their written master's thesis.
That's right. Yes.
So it's a win-win situation.
And they can do as long as a 3-month, or they can do a month now, a month later, and a month down the road. So
Right.
they're very flexible.
Right.
And you may actually have your AHEC or may actually have a search contract.
Okay, I'll check into
Yeah.
it here.
Okay,
Thank you
good.
very much.
You're welcome.
It's a great presentation.
Thank you very much. Hi, good.
I'm Renee Bishop. I'm
Hi, very
program
nice.
manager at the Global Health Center here,
Uh-huh.
and we send students and residents internationally to
Yes.
do experiences. And I'm wondering, has this been tested at all or adapted for use of trying to?
Well, I think it would work.
Yeah, I think so,
I think
too.
it would work quite well.
I'm sure there would be certain cultural.
I could probably say there's certain places in Louisiana that I would consider international.
Sure, of course, and of course New York too. To be
Yeah,
honest.
absolutely, yeah.
Because we have programs in
I
something
think
like 16 different places.
I
too.
think I could work really well. When I was at Tulane, I left there in 2002. But when I was there from '95 to 2002, we had a very active international elective program.